Dear patient, dear friend, and dear colleague, today's a long lecture on neuropathic pain after prolapse surgery. And today we'll not talk about laparoscopic prolapse surgery we have already done with the sacropexy. We will not talk about the TOT or TVT procedure, which are surgery for urinary incontinence, but we are talking today about pelvic neuropathic pain after vaginal prolapse surgery. So what patient should know about this surgery? So there are different surgery, and I will not talk about the vaginal mesh surgery because except the TOT and TV procedure, since the statement from the FDA for many years, more or less nobody is using mesh by vaginal approach. And it's true that for 15 years, 20 years, when we introduced such kind of procedure in gynecology, as a neuropelveologist, I saw a lot of complication. I found mesh everywhere in the pelvis, close to every kind of nerves. It was awful. So at that time, I had to perform a lot of laparoscopy for removal of mesh from around nerves everywhere in the pelvis. So the lecture today will focus on three different vaginal surgery for prolapse situation in women. The first is what we call the Amraj-Richter procedure. It's a fixation of the vaginal calf or apex to the sacrospinous ligament. And gynecology, usually you are doing that on the right side. Some gynecologists are doing that on both sides. Then we have the McCall coldoplasty, so patient where you perform a vaginal hysterectomy. And at the end of the procedure, you fix the sacrouterine ligament to the vaginal calf. And to bring a little bit elevation of the vagina, you make a suture from usually the left uteral sacral ligament, so your own tissue to support the vaginal apex. On the left, because most of the surgeons are right hand and are doing that on the left from the patient. And then we have another, what we call the colporaphy, the vaginal colporaphy. You have an anterior one, posterior one, anterior one to treat what we call cystocele. So it's not a vertical prolapse of the uterus. It's the bladder is falling down inside the vagina, what we call cystocele. And dorsally, the rectum can do exactly the same and use a protrusion inside the vagina that is what we call a rectocele. In both procedures, you open the vagina, you take some fascia, some muscle on the left, on the right, and you bring them together on the midline with suture. So you bring the rectum down and you bring the bladder up. But that is not a treatment of the vertical prolapse of the uterus. So, what can go wrong, like in the same pelvic neuropathy? So, the Amraj-Richter procedure on the right side is well known for to be able to induce a neuropathy of the pudendal nerve on the right side, because the pudendal nerve is just behind the sacrospinous ligament. So, if the surgeon go a little bit too deep with a suture, then you can entrap the nerve or even tied the nerves that will over time and use over time over a few days and use to a death of the nerves. The McCall coldopathy usually is on the left of the patient, and when you follow the sacrouterine ligament, you will reach at some point the sacral plexus, and then if you go a little bit too deep, you will put a stitch on the sacral nerves that will induce the different well-known pain like sciatic pain, vulvodynia, etc. And the colporaphy, the dorsal, not really, but the ventral colporaphy, if you go a little bit too high, you will come in direction close to the dorsal nerve of the clitoris, the punatal nerve, and sometimes even the genitofemoral nerve. So all these nerves are in danger, of course. Now, like always, patient will develop neuropathic pain. Neuropathic typical is burning sensation, stabbing, or electrical shock like pain. That is typical for neuropathic pain. Usually neuropathic pain are quite high, more than 5 on a scale from 0 to 10. 10 is the worst pain ever, 0 is no pain. Now, depending from which nerve is involved in the lesion, the patient will develop pain in groin, for example, genitofemoral nerve, vulvar anus pain, it's the pudendal nerve or the sacral nerve root. Inentine is the genitofemoral nerve, buttock and legs, dorsal aspect of the legs, that is a sciatic nerve, that is a sacral plexus. So patient may develop some numbness that is likely in favor from a lesion of the nerve, because when you have an irritation of the nerve, the patient will feel even more, while when the surgery induced nerve damage, the patient will feel less, and it's what we call hypoesthesia or even numbness. Tingling is a typical neuropathic pain. Of course, painful during intercourse. If you have a lesion of the genitofemoral nerve, the pudendal nerve, or the dorsal nerve of the clitoris, dyspareunia up to apareunia, that means sex is not possible anymore. And of course, because the nerve of the bladder and the rectum are contained in the sacral plexus, if you have a lesion after a McCall, the patient will have dysfunction of the urinary and bowel function. If there is a lesion, they will have difficulty to empty the bladder and the rectum. If it's an irritation, they will develop symptoms like an interstitial cystitis or a urinary infection, or the bowel irritabilis. So now, like always after surgery, even more after prolapse surgery, and even more after mesh implantation, the problem is the diagnosis. The problem is the misdiagnosis. And for most of the colleagues, to develop a pain after the surgery is something normal. Normal to develop pain, the classical normal healing pain. And then after a while, when we are not able to help the patient, the proper diagnosis or the next diagnosis with psychosomatic disorder, even more when the patient is coming back several times over months after the surgery and always report about burning pain in the vulva. So as a gynecology, we will open the eye, we'll take a look. At the beginning, we'll suspect an infection, so we are giving some antibiotics, some pills, some suppositorium, maybe some treatment again mushroom. And at some point, we are at the end of our therapeutic option. And then when we don't know and we don't see a cause for the pain, it's easy, especially in situation of vulvar pain, to give a name like vulvodynia and to send the patient to sexual therapist or to psychologist. Of course, if the patient is sent to a urologist, he will suspect an interstitial cystitis. If the patient is sent to a physiotherapist, he will suspect a myofascial pain. And if the patient is sent to a gastroenterologist, he will suspect an IBS, irritable bowel syndrome, or in gynecology, a very, very well-known syndrome. So when a patient has pain and nobody knows what really the cause, it's easy to say it's because of endometriosis. So the way how the patient are coming in the neuropelveological situation is more or less the same. The patient report, I had a surgery for prolapse, a vaginal surgery. Now I can sit without pain. That is a very strong argument, for example, for pudendal neuralgia. Or the patient, the colleague said, it's in my head, but my pain is real. Yes, we have to believe as the patient. When the patient underwent a surgery and come with a burning pain, it's probably a neuropathic pain and not a psychological one. The patient will say, my legs burn, my vulva is numb, I've lost control. But most of the gynecology told me that I have vulvodynia. Vulvodynia is not a disease. Vulvodynia just means you have pain in the vulva, nothing more. So next kind of report, everyone keep telling me it has nothing to do with my surgery. It's clear as a surgeon when we perform a complication, it's difficult to accept that we have made a mistake. Even more when the pain starts to develop months or even years after the surgery, then it's clear, nothing to do with the surgery. But you remember from the previous lecture, when you have a secondary lesion, that means you perform your surgery or even you bring a mesh in the pelvis, and your body will develop some scar tissue. This scar tissue can start to develop pain even 30 years later. But 30 years later, nobody will come back on the surgery 30 years before and to say, oh, it's probably to this surgery. So, because for most of the surgeons, most of doctors, when you perform a mistake, the patient will develop the pain directly after. Yes, when the patient develop, or if you induce as a surgeon a primary lesion, but if it's a secondary lesion, it could be years later. I see patients with pudendal neuralgia alcohol canal 30 years after vaginal delivery. So it's really not uncommon. So I no longer have a sex life, just a simple touch to my vulva trigger unbearable pain. My pain is destroying my relationship, even my family. Yes, it's mostly like that because when a patient is suffering from pain every day, day and night, on a certain point, it will destroy the family. At a certain point, the husband, the kids, the mom, the dad, will not want to hurt every day, pain. And that is the point where I always mention that I think neuropathic pain is much more painfully than endometriose pain. Of course, endometriose pain is really a strong pain, but a lot of patients have pain only during or around the mass bleeding, while neuropathic pain is every day, every night, every single day of your life, more or less, and you will destroy your family, you will destroy your private life, your social life, your work life, and at some point, as a consequence of the neuropathic pain, you will start to develop psychological trouble. That is clear. So, once again, the key neuropelveology is to find out when do symptoms start. Directly after the procedure, we are talking from a primary lesion because of a thermic damage or a cutting of the nerve or stitching on the nerve with a suture. If the pain develops months or even years later, or even decades later, we are talking from a secondary lesion. And then it's not because of the surgery, but because of the scar tissue developed, that the body developed after the surgery. And of course, when you bring a mesh within the body will develop even more scar tissue. So mesh induce more fibrosis and expose much more the patient for secondary pelvic neuropathic pain that surgery without mesh. And then the patient can develop nerve entrapment. So the strategy, the key is not the surgery. The key in the first line is not to be able to dissect the nerve. The key is a proper neuropelveological workshop. So you need a clear medical and surgical history. You have to find out the exact history of the pain, when the pain developed on the left, on the right, after which kind of surgery. And that is a very, very big advantage to be a gynecologist, to be a pelvic surgeon, because as a pelvic surgeon, you know which procedure may expose which nerve for primary or secondary damage. And that is a big advantage comparing to neurologists who have not the knowledge to know McCall procedure may expose the sacral plexus on the right, on Amreich Richter may expose the pudendal nerve the McCall on the left, the Amreich Richter on the right. And neurosurgeon and neurologists don't have the knowledge and have no approach within the pelvic cavity. So neuropelveology don't belong to neurology or neurosurgery, and of course don't belong to gynecology, because a nerve entrapment lesion is a neurological issue, not a gynecology. So you need a clear clinical nerve mapping to know where is the lesion in the pelvis, on the right, on the left, close to the sacrum, close to the Alcock canal, close to the sciatic nerve, before you decide a treatment, and even more before you want to go in the OR, you have a clear vision in mind, which nerve, in which location in the pelvis. Otherwise, you will make maybe even more pain after. If you try to dissect all the nerve and to find out where is the problem, you will perform a lot of unnecessary dissection that may expose the patient for further pain she didn't have before your surgery. Of course, vaginal ultrasound with Doppler, because a lot of these patients with secondary fibrotic development in the pelvis develop at the same time atypical vessels. So before you go in the OR, you have to know which vessel and where in relationship to the nerve, because once it's clear, the main danger of this procedure is a bleeding. And I'm talking from huge bleeding. You can kill a patient if you're not trained in vascular surgery or if you're not a neuropelveologist. Of course, you can use nerve block if you suspect pathology of the nerve outside the pelvic cavity. For example, the pudendal nerve at a portion within the pelvic cavity and outside the pelvic cavity below the pelvic floor. So if you suspect it could be below the pelvic floor, it makes sense to use a selective nerve block. And if the patient develops pain reduction more than 50%, then you can even use Botox, but outside the pelvic cavity, not within. And of course, an MRI, I always advise an MRI in any case to rule out another cause, because you can suspect a secondary lesion due to previous surgery, but you have to exclude endometrium, you have to exclude a clip, you have to exclude a schwannoma or any lesion or other lesion of the pelvis. You have to avoid, in any term, you have to avoid surprise during the surgery, because the pelvic nerve surgery is difficult enough. You don't need a surprise, a big issue you was not expected before you go in the OR. So the treatment option, like in all secondary and primary nerve lesion, it's you can use Botox for all the nerve outside the pelvic cavity. Within the pelvic cavity, you have the surgery, and when you have a nerve damage, the best way is to use neuromodulation, and you can use sacral neuromodulation, but within the pelvic cavity, you have to bring the lead electrode for selective stimulation of the nerve injured. For example, you have an injury of the pudendal nerve within the abdominal cavity. It makes no sense to perform sacral neuromodulation, because to stimulate one nerve root will never block pudendal pain. So, but by far the most frequent and used procedure in such a situation is the nerve exploration decompression. That means the nerve release. And once again, it makes no sense to open everything if there is a mesh, to remove the mesh, to remove the stitch, because if you do that, the patient will have a recurrence. So the key is to release the nerve. And release the nerve, you have always to start in normal anatomic condition. So to say, I have performed a vaginal prolapse surgery and Amreich Richter from below, so I will try to release the nerve from below. No way. You will be not able, because if you come from below, you will attack the scar tissue. And the higher you will go, the deep in the vagina, the more difficult it will be, the more dark it will be, the more narrow it will be. And when you try to cut the scar tissue, you will have a high risk to induce a nerve lesion. So better to start from behind by laparoscopy, to find the nerve in normal anatomical condition, and then to remove or to open the scar tissue in order to release the nerve, because that is the key, to release the nerve. Even to remove the scar tissue is not always the best, because if you remove scar tissue, you will induce the next scar tissue and maybe the next entrapment. So the surgeon have to be aware, the less he will do, the better it will be for the patient. The key of the procedure is a nerve decompression. No more, but no less. So, key message for you, for patient: chronic pelvic neuropathic pain, mean burning pain, electrical pain, pain every day of your life after vaginal prolapse surgery is real, but we can do something, we can treat you. Nerve damage can occur even without MAGE, but in most situations, patients are suffering from a secondary nerve entrapment that from a through surgical nerve lesion. And the surgical removal of mesh is not the treatment of choice or the removal as future. The treatment of choice is the release of the nerve. And for that, neuropelveological workup, preoperative workup, bring a unique expertise to this problem. You have, once again, before you anything do to treat this patient, to treat you, the neuropelveologists have a clear diagnosis, which nerve, which level in the pelvis, primary or secondary lesion, neurogenic or non-neurogenic. And based on all this information, he will be able to advise a personalized treatment, something just for you, because every nerve lesion is a unique and single situation. So don't ignore chronic pain. You have not to accept that it's normal after the surgery, after vaginal or laparoscopic prolapse surgery. If you develop leg pain, buttock pain, it's not because you have underwent a gynecological surgery and now you have an orthopedic surgery, that both are not linked together. Seek neuropelveological evaluation if the symptom persists or even increase, and you have to be aware that there is a hope for you, but the diagnosis is the key. Without good diagnosis, even when you have a good surgery but in wrong nerve, it will not help you. The key is the right diagnosis and the right adapted treatment for your single case. And for that, you definitively need a neuropelveologist. And once again, I thank you very much for your attention. Keep healthy and see you the next time for probably lecture on neuropelveology and gynecology or endometrial surgery. Thank you very much for your attention. Bye bye. Big hug.